Hello, my name is Mike Waldron. I'm your instructor for this class. We're going to go ahead and talk about some of the changes in the rules and regulations as they apply to EMS. These rules were in effect as of September 9th, 2025. And we're going to go talk about rules applying to licensure and renewal of EMTs, scope of practice, advanced directives, and we'll briefly touch about the Air Ambulance and Fund Act rules. Again, this is not a complete review of the rules and regs. I'm just hitting the big changes. The copies of them are available within the course. You can download them. There's two versions. There's a version of just a PDF, and there's a PDF that's called Redline, and which actually you can go through and see what's been changed, what language was stripped out, and what language was added. So if you want to, for historical reference, those are available in your class. And again, please don't take everything I say. Again, I'm only hitting the high points, so you're responsible for knowing all of it. One small change, but it kind of is big for the Bureau. For years, the Bureau was under the Department of Health Epidemiology and Response Division. It's now been moved under the Center of Health Protection. It doesn't change what the Bureau does. It doesn't change what we do. It doesn't really change the day-to-day operation of the EMS. It's just what you'll see is maybe change it different on the letterhead and in reference to organizational structure. What's been a part of the regs for years is, how we can use, or our limitations of using the patches, insignias, the terminology as a. What was interesting really was nothing in there that kind of restrict non-EMS people on how they can use the information. So it's just language in there that someone can't go out and impersonate themselves as the paramedic or EMS service. Provide a little bit better protection to us as a profession and to the public. In the definitions, a lot was cleaned up, but really three things stick out as really big changes. And that's adding these terminologies of disqualifying criminal offense, immediate suspension, and summary suspension. A disqualifying criminal offense is you're arrested for a wide variety of issues that you can be arrested for. The Bureau would kind of remove any loopholes, list out all the statutes that this applied to in the criminal. And if you're arrested, the Bureau can temporarily suspend your license while you're going through the trial process, or at least until the licensing commission can review. These changes here are not to strip away the EMT's right to due process, but to protect the public. If you have somebody who is a danger to society, you don't want to spend 2 years for it to go through the legal system before you take action. And that's what these changes are. So disqualifying criminal offense is a list of the various criminal offenses that can impact you as an EMT. One thing important to remember is your obligation as an EMT to report any infraction and first responders to the Bureau. If you got arrested for any offense, you must report to the Bureau. The Bureau may or may not elect at that point in time to suspend your license pending review by the Licensing Commission. But I will promise you, if you do not report it and it is discovered later on, it's going to be a far worse situation. So, unfortunately, say you're carrying some ammonia in the back of your truck, you got cited by state police for transport of hazardous material without a placard, which is a criminal offense, you reported the Bureau. Is that going to get your license yanked? Probably not. But if you don't report it, you are going to get your license suspended and it may be revocated. So, when in doubt, if you're wondering if I'm affected, the simplest solution is call the Bureau. I will also kind of remind that if you know of someone, you're a service director, and one of your employees got arrested for something, and they don't report themselves to the Bureau, so you're responsible. You are equally responsible for reporting them as so. Kind of little thing to kind of keep in mind in there, and that's not new. That's always been a part of the regs. So with that, there's two types of suspension that can take place. One is what we would be called summary suspension, and these are people that have been you've been declared a person been declared incompetent by the court, or they've been arrested under one of these disqualifying criminal offense. Again, the Bureau notifies you your license has been suspended, and you're given a date to present yourself to the licensing commission. Immediate suspension, those things are not criminal offenses. If someone has been, gross malpractice, and the Bureau feels that these are a threat to the public safety, license being suspended, a hearing date set before the licensing commission. Again, two goals of this. One, to make sure the public's protected, but two, making sure that the EMS provider has the due process that due to them. We'll talk a little bit more about this and the actual disciplinary action changes in the regs. One change, which doesn't actually are not part of the EMS regs, is who licenses ambulance services. For years, it has been licensed by the PRC, the Public Regulatory Commission. It is now under the New Mexico Department of Transportation. Doesn't really change day-to-day operation. The Bureau still does what the Bureau does, still licenses the EMS providers, certificates, medical rescue, and area ambulance services. Out-of-state students, again, doesn't affect all of us that much, but if you have a student, and this is referring to EMT intermediates or advanced EMTs and paramedics coming into the state, it's very common on the border areas to do the clinicals or internship. When they come in, they have to notify the Bureau. The service should have an appropriate affiliation agreement to protect the service, but those EMTs, those individuals coming in must be licensed at least at the EMT level in the state they're coming from. Obviously, if you're coming in as an EMT, you don't have a license yet. But again, that's different between EMT taking a blood pressure and an intermediate starting IVs. So, kind of important for service directors and training coordinators is your obligation to verify that these people do have their license and that they notify the Bureau. Change, it kind of makes it a little easier now for out-of-state EMS providers coming in. And when an out-of-state EMS provider comes in, they still have the same process. They apply for licensing, they get the background check, fingerprint, and pay their fees, and they get a temporary license. In the past, they would have to, within 6 months, take the reciprocity exam. Now, if the service director and medical director verify that they're competent, they don't have to take the reciprocity exam, they get a full license. The Bureau recommends that you wait at least 4 months into their employment to validate them, to making sure that that they are really good to go. Again, saves them the trouble and hassle to have to travel to Las Cruces, Albuquerque, or Clovis to take the exam. Now, first responders, EMT, and intermediates still must complete a Bureau-approved transition course, regardless if they're affiliated with the service or not. Paramedics do not have to take the transition course. The licensing process. When an individual completes the training program, they now have 12 months in which they must do their first attempt on the licensing exam. And then once they do their first attempt, they have a maximum of 6 attempts to pass or 24 months. If they don't take their test until beyond 12 months, the first attempt, they fail it more than 6 times, or they take more than 24 months, then they must go back and repeat the training program that they were trying to get licensed at. The Bureau does have the prerogative to make exceptions, but that's on a case-by-case basis. Kind of a big change as far as for us for years. We've always had that kind of screwy thing where we had to have our CEs done by December 31st, but we didn't renew until 3 months later on March 31st. Now you can complete your CEs up until March 31st. So avoid the panic of trying to get it all done before the end of December. Now you can wait and worry about having it all done by the end of March. One important thing to remember, even though you have more time to do your CEs, you still have that March penalty month that you pay 3 times the renewal fee if you're renewing in March. So, best advice, get your stuff done by the end of February, avoid the fees, and avoid that mad rush to make sure you get enough CEs. First responders, First responders can take the National Registry to become licensed, or they can take a Bureau-approved exam. And what the Bureau has done is the course final exam in all the training programs in the state. By passing that course final, that is the licensing exam for the state. So a first responder completes the course, passes the exam, they've made, along with their CPR card, their licensing and background check, they can go ahead and apply for a license. They do not have to take the National Registry. That's an option for them. Not a new change, but just a reminder that no more than 50% of your hours can be asynchronous versus synchronous. Synchronous is live, and it doesn't matter if it's online on like a Teams or Zoom format or actually in a classroom, but you can have real-time interaction with the instructor. Whereas asynchronous is like, for example, this class is asynchronous. You can contact me, but you're going to have to send me an email or a text, and there'll be a delay response. If a recorded class, watching videotapes and taking a test are examples of asynchronous learning. Now, there is no limit on the number of hours you have on synchronous. You can have it all live, but no more than 50% of it can be asynchronous. These are not new terms, just clarifications with them. Reinstatement. This is you walk into your kitchen on April 1st, look on the kitchen counter, and there's your envelope with your license application, your CEs, your money, everything there. You forgot to send it in, but you have everything done. You can go ahead and send it in. You're going to pay not a 3 times fee, but a 6 times your renewal fee. But you get reinstated. But you have to have all your CEs done. You have to have like your CPR card, your ACLS done, and you still have to have fingerprints and any other items that need to be done. Okay, next scenario. You walk in, it is now June 1st, and you realize you hadn't mailed it in. Whole new plan. Now you're going to be the reentry process. You're after May 31st, so now it's going to be a reentry. You have to have at least half your CEs done. You have to have whether CPR and ACLS as a paramedic as well. But now you have to retake the licensing process. That means you go back and you get to retake the National Registry again. No one wants to do that. And, for example, let's say you're a paramedic. Well, in order to become a paramedic, you have to be a licensed EMT. So you'll need to go back and take the EMT course and then take the paramedic course if you fail the test more than twice. So, simple reminder, if you just keep your CEs up to date and send your stuff in on time. Avoid the headache. If not, if you pass May 31st, you're going to have to retake the licensing process. If you fail the licensing process, you're going to have to repeat the course and any prerequisite course up there. Again, it's far easier to maintain your license than trying to regain it. And if it's beyond 2 years, you have to just go back and retake the licensing initial course that you're trying to get licensed at. As I mentioned, this disciplinary authority, this is where the regs specify where the Bureau can take action, again, to protect the public, which is the first order of the Bureau. Second order, though, to ensure that you or the individual has due process. You still have the right to a hearing. Again, if you got a criminal arrest, we know the court system can take 2-3 years for you to go through the court system. The Bureau can make a determination. You have to wait until the end of it. Say it's something like capital murder. Obviously, we don't want someone out practicing. But let's say it's, again, less offense. Vandalism because you decided to get angry and hit somebody's windshield with a baseball bat. Shouldn't do it, but you did it. They could then allow you to maintain your license while going through the criminal process. And again, you can look in the regs and you can see the actual long list of things that apply disqualifying criminal offense. The Bureau does have discretionary authority. Again, if they feel that some action that you've done is a detriment to society, they can take action for a summary suspension of your license and bring you before the licensing commission. So that kind of hits the licensing stuff. Again, those are the changes. But again, you're responsible for making sure as an EMT in the state of New Mexico that you know the regs. So if any other questions, go back and actually read the full regs. Now, with scope of practice now. Again, some of these changes have taken place a while back. It just unfortunately takes several years once medical direction makes changes to the scope of practice for it to be brought to law, because it has to go through a hearing process. So you may have heard of these already. A couple of things. These are reviewed. These have been in the scope of practice for several years. One is community EMS and mobile integrated health. That is if a service wants to provide advanced things that are beyond normal EMS, non-traditional approach to EMS, such as home visit, wellness checks, providing preventive services, maybe integrating with a primary care clinic to, go around and check on their patients. There's an infinite variety of different type of community EMS services that have provided quality care to patients in their community. But you have to complete a Bureau-approved training program, and there's a wide variety of them. You have to apply and be approved by the Bureau. Your medical director has to sign off on it. But you also cannot expand what's already in the scope. For example, if you wanted EMTs to go out and administer some medication into your community, that would be a special skill that you would have to go add that on to your services scope of practice. Critical care critical transport applies to paramedic services, whether air or ground. The individuals have to complete a Bureau-approved course, which is certification, which is right now the CC, critical care paramedic, or the flight paramedic certification exam. Apply to the Bureau. And if they're providing, which obviously for critical care, those items beyond the standard scope of practice, they have to apply with a special skills. And the main purpose of this is allow services that they want to get reimbursement at a higher reimbursement rate from the Center of Medicare Services, CMS. Wilderness EMS has been in the scope. This has probably been the longest one. And actually some of it's really kind of no longer germane to us any longer, because it's a standard of most EMS services for actually clearing C-spine in the field or cessation of CPR. But it's meant to provide care for those places beyond 2 hours from a hospital. You, again, have to have medical director approval. The providers have to complete a Bureau-approved Wilderness EMS program, such as that at the EMS Academy or the Wilderness Medical Association WMA EMT program. And they can provide a little kind of more expanded scope. Probably this is most recent, last 2 years ago or 3 years ago, when the last change the scope of practice was allowing for EMS providers to distribute over-the-counter medication. Again, this is meant for providing services to stand by at a rodeo, fair, or wildland fire. It's not dispensing. You're not, administering medication. You're just distributing. You're basically making it available for a patient to come in and get antacid or ibuprofen or whatever you and your medical director decide that you want to carry. Is still responsible for making sure you do a good assessment, that this medication that they pick is appropriate for them, and that you document it. And it has to be in unit dosage. You can't have a big old bottle of ibuprofen there. You have to have little unit packets of ibuprofen for the patient. But the key thing, and this is the patient self-administering, not you administering. Well, the licensed emergency medical dispatcher, EMD, there are no scope of practice changes. At the EMS first responder, there are no scope of practice changes. At the EMT level, ondansetron or Zofran has been added, the PO form, and it's an oral disintegrating tablet. It's called ODT. It's placed underneath the tongue. It's listed for treatment of nausea, which is a good treatment for nausea. It's a horrible treatment for vomiting. Once the person's already vomiting, Dazatron is not very effective, whether it be a PO form or IV form. So again, use it early, or you're not going to get much benefit from it. At the intermediate level, tricemic acid has been added for patients 15 years and older for hemorrhage, and any patient suffering from postpartum hemorrhage. Oxytocin has been added as well as for postpartum hemorrhage, and clarification on location for IO access. In adult patients, any place is acceptable. That could be sternum, humeral head, tibial, femur, all fair games. Over patients 7 and under, only the proximal tibial and distal femur are appropriate sites. And language was removed because it's outdated. Endotracheal medication administration. One, there's no services in the state at the intermediate level that has intubation. And two, endotracheal medication administration is just not effective means of providing medication. At the paramedic level, chemical restraints, 3 antipsychotic medications were added. Haloperidol, droperidol, and oxazepine have been added. Again, must have your medical director sign off and have appropriate protocols. A clarification that blood products can be administered in patients less than 12 years of age, but you must have online medical control prior to administration. The same reason we talked about in the intermediate and not within the scope of practice. Dexetomidate or Precedex, which is a patient used for sedation. The sending facility wants the patient kept on Precedex. That's not in your scope. The way you fix it, you call your medical director, says it's okay. The sending physician is responsible for briefing you on the administration of it, precautions, and so forth. It is a one-time event. You can't keep doing this all along the line. This is just one, and if you see like you're going to be doing it repeatedly, you need to do a special skills, and it only applies for inter-facility transfer. It does not apply for 911 calls. So, basic review on the scope of practice changes at the basic level. Dazatron Zofran has been added for the PO form. The paramedic, we have chemical restraints, inter-facility non-pulmonary medications. At the intermediate, we had tricemic acid, oxytocin, and clarification in pediatric IO sites, and both underneath the paramedic and intermediate removal of endotracheal medication administration. Okay, advanced directives. Again, what this is not changing, it's not a big redo on the advanced directives that had been done several years ago, but trying to modernize it and more importantly make it consistent across other areas besides EMS. 2 big rules. Remember, when in doubt, start treatment, call MSEP. Go ahead, you provide, oxygen, maybe suctioning, and call and contact your medical control. And we'll talk more about others cases where it would be more applicable. Also, please remember, this is do not resuscitate and do not treat. You're still going to provide suctioning, positioning, bleeding control, oxygen. If you're intermediate or paramedic, maybe you're going to provide pain relief. Again, this is do not treat. This is do not resuscitate. We're not going to be intubating these patients. We're not going to be putting supraglottic airways in. We're not going to be putting defibrillating with AED. So just remember that. That's probably the most important thing. When in doubt, call your medical control, but make sure you start treatment. And a DNR does not mean you do not treat these patients. Our goal is to make them as comfortable as possible. Again, this just makes that language far as the Center of Health Protection that we talked about earlier in the beginning of this discussion, and making sure that these regs are consistent across other places, the language and the Medical Act, the Nursing Act, and so forth, that the language is consistent across all these different regulations. And just again, making sure clarification that EMS DNR, we'll talk more about what most are medical orders of scope of treatment, advanced directives, and patient decision capacity will be kind of talked about. These are definitions that are added. Again, this is supposed to be for that from home, long-term care facility, hospital, across the spectrum of healthcare. The language is the same language, and the patients are getting the same, their wishes are being observed. So, this term most, and sometimes you'll see old terms call it a post, a physician order scope of treatment. What a most, much more explicit on what care can be provided or not provided to a patient. And typically what it says is if it's not listed, it's not provided on a most. So you may have a most that says provide oxygen, comfort, suctioning. It may say, can administer anticholinergic and beta agonist, Atrovent, and albuterol. It may say pain medication administration, but it's explicit what we can do for these patients. Again, and it may be more items that are listed from the EMS DNR. But the key thing is that a most is the same for us as a DNR. If we go into a nursing home and they have a most, we can recognize it. And that allows for, at a hospital, if EMS DNR comes in, it allows for a hospital to recognize that as a most. So again, it allows us compatibility across the spectrum of care. Any provider can write one of these, whether it be a physician, it could be an advanced practice nurse, a nurse practitioner, or a physician assistant can write these orders with a most. And nurses can take verbal orders for most, and this way we kind of get greater access to patients, especially in our rural communities, and we avoid delay, because again, the goal behind these documents is that the patient's wishes are observed. And we don't needlessly treat someone who wants to be able to go pass on when the time comes. So what do you do when you're confronted with it? Verification. And again, you don't have to do a lot of what ifs. The patient driver's license, and again, some may not look at them, but again, you look at the driver's license, they have it on their body, they have an EMS DNR with the same name. You're doing a good faith effort in validating the two. If family members say that's this person, or that you go to a long-term care facility and they say that's the patient, that's suffice. You're just making a good faith effort to making sure that this patient is in fact the person who the EMS DNR is written for. One confusing thing that sometimes happens, there may be multiple documents when you walk in, they're dated at different times because patients change their mind, what they want. And so when confronted with multiple documents, take the most recent one. That's the one you're going to follow. And what essentially we'll do is you just kind of, it supersedes any previous one. So it makes it easy for us, what care am I going to provide? Read the one that's the most recent document. If a patient's traveling with a EMS DNR or a most from their state, we can recognize them. There is language in the regs that states that has to be consistent with the New Mexico regs, but again, most states follow a model legislative language, so they're consistent. Again, comes back, you're responsible in making a good faith effort. You're not responsible to know the language of 50 states. So, you got somebody coming from Virginia, they have a most, they have one in cardiac arrest, the family presents you the most, you can treat that as a New Mexico most or EMS, New Mexico EMS DNR. So again, it makes it pretty easy for us to be able to provide that patient for what they want. Now, back to those questions of when should I call medical control? Anytime you have any uncertainty, you don't know what's going on, you're confused. Again, you got multiple forms there, you're not feel comfortable, make the call. You're not going to get wrong for making a call and getting clarification. They may recommend the simplest thing is transport the patient to the receiving facility and let it get sorted out there if the patient and family consents. If you have conflicting information, or if this is suspected homicide, obviously if the person is obviously dead, you treat them like you would do anybody else. Having an EMS DNR and a homicide on a person who's obviously dead doesn't change anything. This is somebody where you feel like resuscitation might still be effort, you need to do it. But one of the things that did change is the original EMS DNR said if the person had suicide, it invalidated. Well, subsequent legislative action have gone through where a terminal patient can request from two physicians that agree that they want a lethal dose of medications to end their life. So obviously they've made that decision based on their autonomy. They have the prerogative, and just that doesn't invalidate it. Key thing is also durable power attorneys cannot override a MOST or EMS DNR. If it's there, it's valid. Patient doesn't want to revoke it, it stands. Now, a patient can revoke it if they have the decision-making capacity. If they're hypoxic, they got O2 of 60, and they're confused and disoriented, and they're begging to treat me, what you're going to do is you're going to call medical control, you're going to provide oxygen, and you're going to end up transporting the patient. If the patient went into cardiac arrest while in there, you have to make a decision, and most likely it's going to be that the patient was just at that moment was confused, didn't have the mental capacity to do it. When they were in mental capacity and made the decision for the DNR, that's the wish that you need to follow. Again, the most important thing is the patient wishes is what we should be following. However, patient's conscious, alert, and oriented and says, no, I want you to do everything, that invalidates the DNR. As I mentioned, patient autonomy is paramount to this. Only the patient can revoke it. But again, make sure the patient has the decision-making capacity to do so. And again, when in doubt, call your medical control. Just a reminder, so bottom line, it clarifies and makes what we are going to be doing consistent across all areas of patient care. It really doesn't change the language of the language, just clarified that this MOST is interchangeable with the EMS DNR. And again, kind of remember, patient autonomy is what we're really looking to take care of. When in doubt, start treatment, call medical direction, and please, by all means, our goal of EMS DNR is we are not there to resuscitate, but we are still there to make sure the patient is treated and made comfortable. Now, as I mentioned real briefly, we'll talk about air ambulance. I'll just simply say that air ambulance regs were significantly changed. If you're an air medical provider, I suggest you go and read them directly. And EMS Fund Act. If you're an EMS service director and you're receiving Fund Act money, I would go and make sure I understand the new changes. It increases your limit on how much you're going to be able to get. There's some procedural changes. If you have any questions, reach up to the Bureau or to the EMS Region Office to make sure that you understand the changes so that it doesn't affect your funding. This was just a quick overview of the reg changes. This was not a comprehensive review. All the regs are available in the course. If you have any questions, please go look at it. Download them. I would suggest if you're a service director or a training coordinator that you keep a copy of them printed off for review. And that's the end of this. Thank you all very much.